Welcome to The Explainer. Today, we're going to create a kind of visual map to really understand what's happening inside the brain both during and after a traumatic injury. We're going to trace that entire chain of events, from the moment of impact to the invisible chaos that unfolds at the cellular level.
So, you get a blow to the head, right? But that is just the beginning. That single moment kicks off this complex and honestly pretty devastating chain reaction. This whole explainer is designed to walk you through that cascade, one step at a time, to give you a really clear, exam-ready picture of the pathophysiology of a traumatic brain injury.
All right, let's start at the very beginning with the basic definition. What even is a TBI? Well, it's not just a simple bruise. At its core, it's any change in brain function that's caused by some kind of outside force. This is our foundation for everything else we're about to cover. Now, this is probably one of the most important concepts to get your head around if you really want to understand TBI. You have to think about it as a two-hit event. First, you've got the primary injury. That's the immediate damage, the direct result of the impact. But the story absolutely does not stop there. What follows is the secondary injury, and it's this sneaky, dangerous aftershock, a whole cascade of cellular damage that happens hours or even days later. Understanding the second hit is really the key.
Okay, so let's zoom in on that first hit, the primary injury. Now, these injuries can be what we call focal, meaning they're stuck in one specific spot in the brain, or they can be diffuse, which is when the damage is spread out over a much wider area.
So check this out. This slide shows those two types perfectly. Over on the left, you've got your classic focal injury. The brain smacks against the inside of the skull right where the impact happened. That's the coup injury. But then it ricochets, right? It bounces back and hits the complete opposite side of the skull, and that's the contra-coup injury. Now, on the right, it's a totally different mechanism. This is diffuse injury. Just imagine the brain twisting inside the skull. Those rotational forces stretch and tear the brain's delicate wiring, the axons, all over the place.
And a really common result of that focal impact is what you're seeing here, a cerebral contusion. It's basically a bruise on the brain. Just like a bruise on your skin, it's caused by leaky blood vessels. But, inside the skull, there's no room to swell. So this bruise is way more dangerous, putting a ton of pressure on that vital brain tissue.
Now that bleeding, that's where things can get really dangerous really fast. Because when that blood starts to pool and clot, it forms what's called a hematoma. This growing mass of blood starts taking up space it shouldn't, compressing the brain. And this can quickly turn into a life-or-death emergency. Knowing the difference between the types of hematomas is absolutely critical.
All right, first up, the epidural hematoma, or EDH. Just look at this CT scan. See that classic bright white lens-shaped collection of blood? That's it. That's the bleed, and you can see how it's pushing in on the brain. This shape is a total giveaway for an epidural bleed.
Okay, so here's the must-know high-yield info for this one. Why is an EDH such a big emergency? Well, it's an arterial bleed. The pressure in an artery is high, so the blood pumps out fast and the hematoma grows rapidly. This explains that classic and really scary clinical sign. A patient might get knocked out, then wake up and seem totally fine. That's the infamous lucid interval. But then, all of a sudden, they decline incredibly fast. Recognizing that lucid interval is a huge warning sign.
Okay, so that was the fast and furious arterial bleed. Now let's switch gears and look at its counterpart, the subdural hematoma, or SDH. This is actually the most common type of traumatic bleed inside the head. And you can see on the slide, it's different. It kind of spreads out over the brain's surface, right under that tough outer layer called the dura. And this is the key distinction you absolutely have to remember. The SDH is a venous bleed. Veins have much lower pressure than arteries, so the blood just kind of oozes out slowly. That's why the timeline can be so sneaky. It could be acute, showing up in hours, or it could be chronic, taking weeks to develop, especially in older adults. The symptoms tend to creep up on you, a headache that just keeps getting worse, confusion, or just being really drowsy.
And rounding out our trio of bleeds is the intracerebral hematoma. The name kind of gives it away, right? Intracerebral, this bleed is happening inside the brain tissue itself. Those shearing forces from the trauma can rip tiny blood vessels deep within the brain, causing this type of bleed.
All right, so we've covered the immediate car crash, the physical damage from that first hit. But now we have to talk about the silent tsunami that follows. This is the second wave, the secondary injury. It's this invisible, destructive cascade that happens at the cellular level, starting hours or even days after that initial impact. This is often where a survivable injury becomes truly devastating.
Okay, let's really break this down step by step so you can picture it in your mind. It all kicks off when the trauma messes up the cell's normal electrical state. That forces the floodgates, the ion channels, to fly open, letting in a torrent of sodium and, most importantly, calcium. Now, water always follows ions, so water rushes in, causing the cells to literally swell up like water balloons. This is called cytotoxic edema. All that chaos then triggers a massive release of a neurotransmitter called glutamate, but way too much of it is toxic, overexciting, and poisoning the cells next door. This is called excitotoxicity. Then all that extra calcium storms the cell's power plants, the mitochondria, causing them to fail. Suddenly, there's no energy. This whole catastrophic cascade, the swelling, the toxicity, the energy failure, it all leads to inflammation and ultimately cell death.
Okay, so with all this crazy damage happening on a microscopic level, how do you actually figure out how bad the injury is when a patient is right there in front of you? How do clinicians measure this stuff?
Well, the go-to tool, the gold standard, is the Glascoma scale, or GCS. It's a really clever and simple way to get a quick snapshot of how the brain is functioning. It gives you a score from 3 to 15 based on a patient's ability to open their eyes, talk, and move. The lower the score, the more severe the brain injury. It's a fast, standardized way to assess the damage.
But you also have to be a bit of a detective and look for physical clues. And for a very specific injury, a basilar skull fracture, which is a break in the bones at the base of the skull, there are two dead giveaways. You get raccoon eyes, which is bruising that forms around both eyes, and battle sign, which is bruising that shows up behind the ear. If you see these signs, it's a huge red flag for this very serious type of fracture.
You know, surviving the initial injury is just the first part of the battle. For so many people, the journey doesn't end when they leave the hospital. The echoes of that primary and secondary damage can last for a very, very long time, leading to some really challenging long-term problems.
We see a few common syndromes pop up. There's post-concussion syndrome, where symptoms like headaches and dizziness just hang around for weeks or months, even after a mild TBI. For more severe injuries, the brain can become irritable, leading to post-traumatic seizures. And of course, there's the one we hear a lot about now, chronic traumatic encephalopathy, or CTE, which is this progressive, degenerative brain disease that's linked to getting repeated head injuries over time.
So, when you put it all together, it leads us to this massive question for researchers and doctors. We can't turn back time and prevent that first impact. But if we know this devastating secondary cascade is coming, if we can see that biochemical train wreck about to happen, how do we jump in and stop it? How can we protect the brain in those critical hours and days after the injury? That right there, that's the future of treating traumatic brain injuries.